Welcome to today's session on blood supply of heart. Heart is chiefly supplied by two coronary arteries which arise from ascending aorta, immediately above to the aortic valve. So here we can see aortic valves. So just above to the aortic valve, we can see two arteries which supply the heart. So this is the right coronary artery. And this is the left coronary artery. And we can see the semilunar valves guarding the aortic opening. So just above the aortic valves, these two arteries get their origin. So the coronary arteries and their branches run on the surface of the heart, lying within the subpericardial fibrofatty tissue. So these coronary arteries are considered as vasa vasorum, means the blood vessels supplying a blood vessel, because embryologically heart develops from dorsal aorta. Dorsal aorta, which is nothing but the heart tube. The right and left dorsal aorta, they fuse to form heart tube. So heart tube is considered as a blood vessel, and coronary arteries supply the heart tube, which is like a blood vessel supplying the blood vessel. So hence it is a modified blood vessel. So heart is a modified blood vessel which is supplied by coronary arteries, which are considered as largest vasa vasorum. Anatomically, coronary arteries are not end arteries, as they anastomose at the terminal level. But physiologically, that is functionally, they are like end arteries, since they represent the only source of blood supply. That is why blockage of these arteries is very critical, especially in sudden occlusion. Sudden occlusion of these arteries causes the ischemia of a particular heart, leading to myocardial infarction. Let's see about each coronary artery. So first we shall begin with the right coronary artery. So here is the image showing the arterial supply of heart. So the right coronary artery takes its origin from the anterior aortic sinus. So this is the aortic sinus. So it takes origin from the anterior aortic sinus of ascending aorta, immediately above the aortic valve. After its origin from the ascending aorta, the right coronary artery runs forwards between the pulmonary trunk and the right auricle. So here we can see the pulmonary trunk, which is guarded by semilunar valves. So we can see the right coronary artery between the pulmonary trunk and the right auricle, and then it descends almost vertically in the right atrioventricular groove, which is considered as right anterior coronary sulcus. So it is like right coronary sulcus, anterior coronary sulcus. So it runs in the right coronary sulcus, where it descends down towards the inferior border of the heart. So it descends down between the right and the inferior. So here is the right border of the heart. So this is the right border, and from here it is considered as the inferior border of the heart. So at the junction between the right border and the inferior border, we see this coronary artery. It is winding round the inferior. So at the inferior border of the heart, it turns posteriorly to take its course in the posterior atrioventricular groove. So here, after winding round the inferior border, we can see in the posterior atrioventricular groove. So this is the right coronary artery. So it runs in the posterior atrioventricular groove. So this is the right atrium. This is the right ventricle. After reaching the crux of the heart, it reaches up till the posterior interventricular groove, where it terminates by anastomosing with the left coronary artery. So we can see here it gives off a branch which is going into the posterior interventricular groove. Where it contains posterior interventricular artery, and further we can see the artery here ending up by anastomosing with the left coronary. So this is the branch of left coronary artery. So that is the course of right coronary artery. Let's see the branches of right coronary artery. The first foremost branch is the right conus or infundibular artery. So the right conus or the right infundibular artery is the first branch of right coronary artery, and it is also called as conus artery, and this is sometimes termed as third coronary artery if it gets origin separately from the anterior aortic sinus. In 36% of the individuals, this artery may arise separately from the anterior aortic sinus, or it may be a branch of left coronary artery occasionally. And the next artery is the SA nodal artery. We can see an SA nodal artery move towards the base of the superior vena cava. In 65% of the population, SA nodal artery gets origin from the right coronary artery, and in rest of the population it may arise from the left coronary artery or directly from the aorta. The other branches are the atrial branches and ventricular branches. So here are the atrial ventricular branches. So we can see the anterior ventricular and anterior atrial branches. Further, it continues posteriorly to give rise to posterior atrial, posterior ventricular branches. And we can see an artery which runs along the inferior border of the heart, which is called as acute marginal artery. So this is the acute marginal artery. AV nodal artery. So here we can see the atrial and ventricular branches from the posterior side. These are the atrial branches, and these are the ventricular branches. And AV nodal artery. AV nodal artery in 80% of the population, AV nodal artery arises from the right coronary artery. So usually it arises here from the right coronary artery. Posterior interventricular artery, which is otherwise called posterior descending artery. So posterior interventricular artery, it is present in the posterior interventricular groove. So we can see here it is present in the posterior interventricular groove. Let's discuss the distribution of right coronary artery. So right coronary artery supplies right atrium by its atrial branches, and in 65% of the population it supplies the SA node by giving rise to SA nodal artery, which is present in the base of superior vena cava. Then it supplies the right ventricle by means of its ventricular branches, and also partly left ventricle by giving rise to a few ventricular branches, and interventricular septum. So posterior interventricular artery, which which supplies the interventricular septum. That is, the 1/3 of the interventricular septum is supplied by the posterior ventricular artery. AV nodal artery, usually it arises from the right coronary artery, and partly the bundle of his and left bundle branch partly is supplied by the right coronary artery. Let's see the branches of left coronary artery. Left coronary artery, it takes origin from the left posterior aortic sinus. So here is the So it gets origin from the left posterior aortic sinus of the ascending aorta just above the aortic semilunar valve, and it runs between the pulmonary trunk and the left auricle. So here in this image we can appreciate the right coronary artery runs between the pulmonary trunk and the left auricle, which has a very short course between these two structures. Then the right coronary artery terminates by dividing into anterior interventricular artery. So this is one branch. So it divides by terminating into anterior interventricular, which is otherwise called as anterior descending artery, and circumflex. So the other one is the circumflex artery. So here, which is hiding below the left auricle, is the circumflex artery. So generally most part of the myocardium is distributed by the left coronary artery. Anterior interventricular artery, otherwise called left anterior descending artery, travels downwards towards the apex of the heart. So this is the apex. We can see it runs towards the apex of the heart in the anterior interventricular groove, and where it winds round the apex to by terminating by anastomosing with the posterior interventricular artery. Next, about the circumflex artery. Circumflex is a branch of the left coronary artery, runs in the coronary sulcus. So the circumflex artery runs in the coronary sulcus, and it gives off the left marginal artery. So after its giving of the left marginal artery, which supplies the left atrium and the left ventricle, and it winds round the left border of the heart, and it anastomoses with the terminal branch of right coronary artery. So after winding up, so this is the circumflex branch of left coronary artery. We can see it terminates by anastomosing with the branches of right coronary artery. Let's see the branches of left coronary artery. Left coronary artery gives rise to left conus artery. Just like the right conus, we have got left conus artery. Left conus artery is the infundibular artery. It supplies the base of the pulmonary trunk. And sometimes in 35% of the population, we see the SA nodal artery may get origin from the left coronary artery. And anterior interventricular artery, which is otherwise called left anterior descending artery, which supplies the ventricle, left ventricle, as well as partly the right ventricle. So here is the anterior interventricular artery and the circumflex artery. So here the circumflex artery is here. This is the circumflex artery. So after winding behind, it also gives rise to left diagonal artery. Left diagonal artery may directly arise from the trunk of the left coronary artery. And obtuse marginal artery, which is otherwise called left marginal artery. So this is left marginal artery. In 20% of the population, AV nodal artery may arise from the left coronary artery, and it gives rise to atrial branches and also ventricular branches like anterior and posterior atrial branches, anterior and posterior ventricular branches. So let's see the distribution of the left coronary artery. So the left coronary artery, we can see here in this image, it supplies mainly the left ventricle, left atrium via its atrial branches, and anterior interventricular septum. 2/3 of the anterior interventricular septum is supplied by the anterior descending artery, which is a branch of left coronary artery, and it also supplies partly the right ventricle. And 35% of the population, we see the SA nodal artery getting its origin from the left coronary artery, and AV nodal branch, 20% of the population gets AV nodal branch also from the left coronary artery. Major portion of the bundle of His is supplied by the left coronary artery via its two branches called as left bundle branch and right bundle branch. So this completes the distribution of the left coronary artery, and we shall discuss about the coronary dominance. What is this coronary dominance? Coronary dominance is determined with the supply of posterior interventricular septum. So in this image we can see the posterior interventricular artery normally gets origin from the right coronary artery. Suppose the posterior interventricular artery, if it gets origin from the left coronary artery, it is called as left dominant. If the posterior interventricular artery gets origin from the right coronary artery, it is called as right coronary dominance. So coronary dominance is determined by the posterior interventricular artery. So right dominance is found in 80 to 85% of the cases, and rest of the 15 to 20% we may find the left coronary dominance. If the left coronary artery is a dominant artery, usually the circumflex artery gives rise to the posterior interventricular artery, supplying mainly the AV node and bundle of His. That is the reason it is left coronary dominance. And normally we know the right coronary artery gives rise to posterior interventricular branch, which also supplies AV node and bundle of His, making more of right coronary dominance. And arterial supply of SA node. SA node receives blood supply by SA nodal artery, and a branch of right coronary artery, that is majority to 60 to 70% of the hearts, we see the branch of right coronary artery supplying the SA node, and a branch of left coronary artery. In rest of the 20 to 30% we may find branch of left coronary artery, which is usually a branch of left circumflex artery supplying the SA node. And in fewer individuals, that is in 10% of the SA nodes, receive bilateral supply, means SA nodal arteries, they get origin from both right and left. So SA nodal artery passes between the right atrium and the root of the ascending aorta. So we see the SA nodal artery after gets origin, it runs between the aorta to the base of the superior vena cava. It encircles the base of the superior vena cava to supply the SA node and also partly right atrium of the heart. Let's see some clinical correlation associated with the blood supply of heart. So angina pectoris means the blood supply to the cardiac muscles is diminished, means if it is reduced, if the coronary arteries are narrowed. So this reduced blood supply is due to narrowing of coronary arteries. So as a result, on exertion, the patient feels moderately to severe pain in the region of left portion of the chest region and anterior chest wall over the heart, that is where the pericardium is present. So over that area they feel the pain. So it is left portion of anterior chest wall, which may last long for 20 minutes, and the pain is often referred to the left shoulder and medial side of the arm and forearm. So this is called as angina pectoris. In angina pectoris, pain occurs on the exertion and it gets relieved by rest. and this is due to the because of coronary arteries are so narrowed that ischemia of the cardiac muscle occurs only on exertion. Exertion means when you do exercise or when you do more of physical movement. Okay, the next condition is on myocardial infarction, where a sudden block of one of the larger branch of either coronary artery and larger branches of any of the coronary artery usually leads to myocardial infarction, that is inadequate blood flow, followed by myocardial necrosis, means the death of the cells of myocardial tissues, resulting myocardial infarction. So the part of the heart suffering from myocardial infarction, it stops functioning and often causes death. So this condition is termed as heart attack or coronary attack. So the clinical features of myocardial infarction is like nausea or vomiting, sweating, shortness of breath and tachycardia. Tachycardia means increased heart rate, and pain in the chest that lasts longer than 30 minutes, and pain radiates to the medial side of the arm, forearm and hand on the left side. So the patient usually complains of pain on the left arm, left forearm and left hand, especially on the medial side of the upper limb. Sometimes it may be referred to jaw or in the neck also. Coronary angiography. The coronary angiography is a radiological procedure which is usually CT MRI to visualize coronary arteries after injecting a contrast medium into the peripheral veins. So the coronary angiography is usually in localizing the sites of blocks in the coronary arteries. The next procedure associated with the coronary arteries is coronary artery bypass graft, which is called as CABG. That is coronary artery bypass graft. It is often performed in patients with unstable or severe angina due to the obstruction of coronary artery, and a segment of a vein or an artery is connected to the ascending aorta or to the proximal part of the coronary artery, and then to the coronary artery distal to the obstruction. So a coronary bypass graft shunts the blood from the aorta to the coronary artery distal to the blockage to increase the circulation. So this is about the coronary artery bypass graft CABG procedure. Let's see the common sites of coronary occlusion. So the coronary artery occludes at three common sites. One is at the anterior interventricular artery, which is the otherwise called left anterior descending artery. So 40 to 50% of the occlusion we find in this artery. At right coronary artery block, in 30 to 40% of the cases, the right coronary artery may undergo occlusion. And circumflex branch of left coronary artery. In 15 to 20% of the cases, the circumflex branch of the left coronary artery may undergo occlusion. So the myocardial infarction mostly occurs at rest, whereas the angina, that is the angina pectoris, occurs on exertion. So that is the difference which you have to note down here. Anterior interventricular artery, that is the left anterior descending artery, is most commonly blocked. That is also an important point to note down. And coronary angioplasty, this is the next procedure which I am going to discuss now. In this process, the cardiologist pass a small catheter with a small inflatable balloon attached to its tip into the obstructed coronary arteries. So as the catheter reaches the obstruction, the balloon is inflated. So as a result, the atherosclerotic plaque, means where the obstruction is, the plaque made of cholesterol or fat, it is flattened. So the plaque is flattened against the vessel wall, and the vessel is distended to increase the lumen. Consequently, the blood flow is increased. So sometimes transluminal instruments with rotating blades and lasers are used to cut the clot. After artery is dilated, an intravascular stent is introduced to maintain the dilatation. So this procedure is called as coronary angioplasty.